So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening. Hi, everyone. Welcome back. It's so good to see some familiar faces and some new ones. Thank you all for joining us. I know it's been a minute since we've been back in South Florida with this amazing team from Memorial, and we could not be happier to be here. Thank you to all of you also watching live. I want to remind everyone online, please feel free to ask questions as we're having the discussion tonight. And everybody in the room also ask questions as we go along. There's no need to hold your questions till the end. For those of you who may not know me, I'm Danielle Hicks, and I am Chief Patient Officer at GO2 Foundation for Lung Cancer. My role is to really oversee all of the work that we do with the patient and caregiver population around support and education services. So I know most of you and have worked with you in some form or fashion in the past. And if we haven't worked in some form or fashion in the past, please make sure to come and talk to me. A little bit about myself before we start. So my journey within this lung cancer space began in 2003, and some of you already know this. My mom, Bonnie Adario, was diagnosed with stage 3B non-small cell adenocarcinoma. At that time in 2003, she was told that there was really nothing that anybody could do for her. They said maybe they could try some chemo, but because of the location and the fact that it had impacted her aorta, they really didn't think that chemo was going to help much. So that not being a really good answer for her or my family, we kind of put together a multidisciplinary team of our own, doctors from several different hospitals. We just put the feelers out, and I think it's an important kind of segue into what we're talking about tonight in this multidisciplinary space and why it's so important. I'm happy to say that outreach did wonders. And on March 17th, St. Patrick's Day, we celebrated her 19th year of being cancer-free. So, yeah, thank you. And I was talking to a couple of you in the room earlier tonight, and I think one of the things, a takeaway from the last time we were here in this room, and I think Michelle said it was May of 2019, so it's been a while. COVID put a damper on a lot of things, this being one really important one. And I totally lost my train of thought. I don't know what I was saying. I don't know where I was going with that, but we're happy to be back. We're going to start tonight with an around the room. So please feel free, if you don't feel comfortable, pass the mic. Oh, no, I was going to say. What people say, whether we're having the living room where we run it regularly from California or when we're on the road regionally, what I hear over and over and over again, particularly from folks who are a little newer to their diagnosis, is I found hope by coming to this meeting. I found hope by hearing stories of other people living and thriving with this disease. So I really hope the big takeaway tonight for you in the room, again, you watching live, and those of you who will come back and watch post-live, is to find that piece of hope, where sometimes, you know, you're feeling not so hopeful. So I'm going to start the pass around the room, and then I'm going to turn things over to Dr. Reyes to introduce this amazing team. I'm sure you guys know all of them. Oh, I do want to give a shout out to a couple of folks who were supposed to be here tonight but did call and say that they couldn't make it. We know you're watching live, so thank you for joining us for sure. So I'm going to turn it this way, and once we're done with the around the room, I'm going to turn it over to Dr. Reyes. I'm going to come this. You guys want to start? Do you care if we start on this side?
Hello, my name is David Rosa. I started with lung cancer, the 26th of this month is going to be 13 years ago. And I've been having some battles now, you know, with the cancer going to the stomach. I've had several brain tumors, but thanks to doctors, thank God that, you know, we have it at bay, and just struggling to get things better.
Hi, I'm Marilyn Rosenblum, and I was diagnosed in August with stage 4 non-small cell lung cancer. And all I could say is I'm doing pretty good. And I think I have tremendous confidence in my doctors, Dr. Reyes. And I think that's very crucial to have that kind of confidence.
Hello, my name is Oneida McKeechin, and I'm the new Director of Operations for Memorial Cancer Institute, working alongside Dr. Reyes, supporting the community and our patients.
Hello, my name is Adriana, and I work with Dr. Reyes. I'm the medical assistant, help with patients.
My name is Robert De Pasquale. 5 years ago, I was diagnosed with stage 4 lung cancer, and it metastasized to my T5, and I really was scared. I didn't know what was going on. But Dr. Reyes said, come to this dinner, and sitting at the table, there was a woman who was 12 years. There was a gentleman who was 10. So it gives us hope, you know, that things will get better, and it has. I've been 5 years out now, so it's working. So
This way.
Hi, I'm Audrey Allen. This is my husband, Paul. My heroes sit up at that table. Each and every one of you were my medical team. I was diagnosed at the end of 2007, and 2008, I met up with Dr. Reyes as my second opinion. How fortunate for me, because I had been given a death sentence of 6 to 9 months to live. And he treated me aggressively, and I'm grateful and thankful. And beside my husband, Dr. Reyes, you are certainly my hero. So I had a recurrence in end of 2018, 2019, and again, here I sit. So I live in gratitude and, well, just thankfulness for all the things that I've been able to see all these years and the things that I've been able to share. So many thanks. Muchas gracias.
My name is Anelita, and I have lung cancer. And I am hopeful, very hopeful, that I finally will be able to conquer it. I am very thankful to the Cancer Institute, to Dr. Block, to Dr. Reyes, for everything you guys do, because it takes your kindness and your knowledge and your expertise to know, to make us feel the way we feel. So I have hopes in the future. Thank you.
My name is Mihaela. I have been a nurse navigator since 2017. My background is obviously a nurse. I started in oncology as a research nurse, and I continued as a navigator. I feel truly privileged to work as a facilitator, to help patients to navigate through their process of cancer care. My goal is to make sure you have facilitating access to care, that you have all the information that you need to make your own decisions about your care. Also to help and provide emotional support as you need, and also to make sure you understand your plan of care, you understand your expectations as a patient, and also the fact that we are here to help you as a team. I work very closely with Dr. Rice, Dr. Block, radiation oncologists, and other medical oncologists at Memorial. And my role, the most important part of the day, is to make sure you get the best experience with Memorial, the best service that we can possibly offer you. Why lung cancer patients? I studied in research, conducting research study with, for lung cancer. So I participated obviously with Dr. Reyes and the other medical oncologists to help promoting immunotherapy treatments, targeted therapy treatments. So I developed special interest in this type of patient population. There's more to say. What I noticed, what's different from other patients with cancer, is that by the time they get to see us, they are obviously, most of the time they are diagnosed with advanced stage lung cancer. So they need a lot of support to understand the diagnosis, what staging they are in, and what pending tests they have to complete, and how they get there. So that's a lot of need for navigation from this standpoint, as well as emotional support, because there are a lot of ups and downs. But as you see, we have very amazing stories about patients living with this as a chronic condition. So that's it. Yeah.
Okay, my turn. My name is Mark Block, and I am a thoracic surgeon, which means I do surgery in the chest and with a specific focus on the lungs and therefore lung cancer. I finished my training in 1997, and that included a three-year stint at the National Cancer Institute, where we were actually doing some of the very early work on immunotherapy. So it's really exciting to see that finally come to fruition. I've been here in Florida for almost 20 years, heading the Division of Thoracic Surgery within the Memorial Healthcare System, and really having the tremendous pleasure and enjoyment of working with this multidisciplinary team to help advance the cause for our patients with lung cancer. I think over those 20 years, what we've seen is the role of surgery, rather than shrinking, it's actually growing. And I think that's the whole concept of the multidisciplinary team is becoming much more integrated. And I think that's a testament to the developments in all of our individual fields, and we can address those later. But there have been advances in surgery, in oncology, in radiation therapy, immunotherapy. And rather than separate our specialties, it's actually, I think, brought us more together and helped us function more as a team, as an integrated team, bringing everyone together for the patient. Why lung cancer? Well, when I started 25 years ago, there was a lot of nihilism and fatalism around lung cancer. As probably everyone knows, it's the most common cancer killer, but it was getting really little attention. And the only way that someone would get cured was with surgery. So we had this very privileged window of being able to see patients with lung cancer who would get cured. And that gives you an optimism towards the disease that this actually is possible, we can do this. Of course, 25 years ago, that was pretty rare for somebody who had advanced stage lung cancer. But one of the really exciting things is that over the last 10 years, 5 years in particular, we are now not the only ones who can see a patient for follow-up 5 years and 10 years later, as we've seen in this room, that people with advanced stage disease can also come back to see their physicians having survived the disease. So that progression, going from a place where very few people were able to be cured and there was so much fatalism around the disease to where we are now, I think is one of the things that makes being involved in lung cancer care so exciting. So look forward to the rest of the living room and to your questions and engaging all of you. Thank you very much.
My name is Luis Raez. I was born in Peru and I came in 1993 to the United States. The reason that I came is because I have some passion for research, for try to beat the odds and try to save patients. And I thought this land was perfect for that because that is a place in the world that gives more opportunities to do that. And I graduated in 1999. And the reason why I embraced lung cancer is because among the faculty that I have in University of Miami, I was very impressed about the lung cancer guy, the lung cancer faculty, the doctor. His name was Cassius Rihar. He was very passionate, very strong. He fight every single patient. He never give up. He always hoped. All of that energy, I was very impressed. And then, like everything in life, I wanted to stay in the university as a faculty, and I was so lucky that there was a job available to be his assistant. So I took the job. Unfortunately, it was only 6 months because he died. These are the things of life. Sometimes the patients, we're telling some bad news, and the patients look at us, and nobody has life granted. The patients outlived the doctor. The doctor died. He was only 48. And I only got the pleasure to work with him 7 months as a colleague. And anyway, I tried to do what he used to do. And for the next 20 years at University of Miami, and now 10 years at Memorial, we are very passionate to fight for our patients, to look for always the options to cure them or to prolong their life. And I think, with the help of a multidisciplinary team, this has been successful, Sometimes it's the surgery, sometimes it's the biopsy, the radiation, the protocol, the new drug, but there is always hope because we are trying to fight. And that's why this is a very important cause to me, and I decided to dedicate my life to fight lung cancer, and it has been the first 10 years were very difficult because I thought maybe I make a mistake, because we didn't have too many developments, and now we are so excited about molecular therapy and things like that. And but this is our passion, If you like to find passionate doctors fighting lung cancer, we have here 5 and many more around. And we are very happy to be here. We are missing Monia Dario tonight. I hope that she's doing well. But one of the reasons we joined the Andario Foundation 9 years ago is because her passion. We found that the patients also can carry the same passion, and we can join together and strengthen forces and make things better together. And that's why we're together here. And this is our commitment, for us, from personal commitment, from our healthcare system. We're going to fight for you always, and we'll never give up.
My name is Ana Botero, and I am also a foreign physician. I'm from Colombia. As I said, joking, in my other life, I was a surgeon, and I retrained in St. Louis, Missouri, in Washington University as a radiation oncologist. And I have been in practice already very, very long. Actually, today is my birthday. So a very long time ago, and I moved from St. Louis, Missouri to South Florida, almost like a Dr. Block, probably 18 years ago, and I joined the team of Memorial, which I terribly miss, but despite that it was a great group, I am now working with Baptist Hospital. And I think that is not about the institution. I think that is just all about the patient. And I think that having a good communication with the, other physicians from other institutions is crucial. And the multidisciplinary approach doesn't mean necessarily the same institution, but just communication with other physicians. I think communication is extremely important. I think as a physician, we have to be involved, not because I'm radiation, I'm only focused on radiation. We have to be involved with Dr. Block. We are part of the American Lung Society. We're in the board, just basically educating and preventing that all generations get involved in smoking. Obviously, not all the lung cancers are related to smoking, but you know, the young generations preventing smoking, quitting smoking, early prevention, early detection. But as a radiation oncology, you know, technology makes a huge difference. And working hand to hand with the surgeons, with the medical oncologists, with the nurse navigator, radiology, pathologists, you name it, you know, everybody in the team is very, very important, but technology is extremely important. And luckily nowadays, I think that South Florida is very, very lucky because the multiple institutions in South Florida has a lot of technology, and pretty much compared with any other part of the world. And we have different technology for different staging of the cancer. So if it's an early stage and the patient is not candidate for surgery, the good thing is just discussion, you know, what is the best for the patient. So early stage, we have now radiation with very good results also for those patients that are not candidate for surgery. Locally advanced, thanks to the chemo, thanks to the target therapy, immunotherapy. Now we see patients surviving longer, surgeons being a little more aggressive because of the benefit of even doing surgery for those that for many, many years we used to say they are not candidate for surgery. And I think that one of the major achievements is for those stage 4 that sadly still we see probably maybe a third of the patients or maybe more. Eventually, they develop more, not necessarily at the time of the diagnosis, but during the years pass by, they develop metastases. But for those patients that we know that they have a little bit more some special individualized targeting, you know, that they can do with target medicine or with the immunotherapy, radiation also help tremendously because we know that given doses that we never thought that we were going to be able to do it with the technology available, we escalate the dose, we target those lesions, we eradicate. We're not talking about just palliate the pain or the obstruction. We eradicate the disease. And we know that by doing that, your own immune defenses and everything, plus the immunotherapy and the systemic therapy, the patients do much better. And we have the, proof among here many patients that basically they kind of go from one treatment to the other. They go for a period of time without no treatment, but certainly for those patients, radiation helps a lot. And even for those patients that for whatever reason they don't respond, and sadly they are not among us, I think that as a physicians, we also have the goal of make them comfortable and give them quality of life. So yes, work as a team is very important, and I think that I'm very proud that my colleagues, still I call them colleagues and friends because we work together, even in different institutions. Technology makes a huge difference in radiation oncology, and I think that we're definitely making a change in the prognosis of the lung cancer patients. So I'm very enthusiastic about that, and as Dr. Reyes said, I never give up, and when I said give up, it means not to drag the patient for radiation to the last, when they are not doing well, but just basically to recognize the difference, when you can really help the patient with the treatment and when you basically have to comfort, make them comfortable, and give them some peace of mind and help them to die. But definitely is making a huge change. The number of patients of survivors are amazing. I have been long enough in practice to see that the survivors with breast cancer, now we see many, many survivors of lung cancer doing well with relatively good or relatively good, good quality of life or relatively good quality of life. They certainly are very thankful to be alive. And for many years, being alive, stage 4, that it was unheard. When I started working with Dr. Rice, I remember that I was, doing the technology, and Dr. Rice said, just go ahead and treat it. But it's a stage 4. How, it's unheard to treat a stage 4 with radiation, especially with ablative doses. But we did it, and without no further studies, we start realizing that our patients start being, live for 5 years, 6 years, 7 years, and the patient says, when I can say that I'm cured? And we cannot say that we cure a stage 4 because we will be in some pavilion in the psychiatry, who knows where. But definitely, I think that we're heading to that. And even the patient that has full of metastases, we're seeing now significant improvement, and we make them with less metastases and eventually eradicate, maybe hopefully one day eradicate the disease. But I think that the future is just having a lot of hope for cure the cancer.
My name is Helenis Domingo. I'm a medical oncologist, a thoracic oncologist at Memorial. I work alongside Dr. Block and Dr. Reyes, and used to work with Dr. Botero as well, Mijaela. I'm from Cuba. I came to this country when I was 15. I did all my training here. I did my fellowship in hematology oncology at UIC in Chicago. But prior to that, I did my residency training at Jackson Memorial, where I trained under the supervision of Dr. Reyes, who's my mentor. And he was one of the big reasons why I decided to do lung cancer oncology, in addition of disease that's still being the #1 cause of cancer death. And having so many new discoveries that make it very exciting and gives us a lot of hope that we can now cure so many more patients. I remember when I was a fellow and you had a diagnosis of stage 4 lung cancer, it was pretty much a death sentence. And now we're seeing so many patients that are in remission for so many years that I think, it gives me a lot of hope. And I can also see that in Dr. Reyes, who's a leader in our department, also spearheading a lot of the research that we're doing at Memorial. And that's one of the main reasons I went into lung cancer.
Okay, so this is supposed to be interactive, so we really want to hear some comments and opinions. And first of all, I want to acknowledge the caregivers, the caregivers, the friends, the spouses, because we have learned in this journey that the patients are the ones that are suffering, but the caregiver is not allowed to say that he's suffering or she's suffering, He only is silent, always next to the patient, and I have learned that a lot of them carry a tremendous burden, and I have family members also that have had cancer, and I realized that this is very important, that also as cancer programs, we are with you. We really care about the caregivers, and we can provide some sort of support to you too. And that's important because we're talking tonight about multidisciplinary care, and we don't have time to present everything because we have here navigator, surgery, medical oncology, radiation, but we also have pathology, we have nutritionists, we have integrative medicine, we have palliative care, we have pain management. That's why I think the management of lung cancer has been improving tremendously, because now we acknowledge that we have to fight every corner of the disease. We cannot do anything left behind. If a patient is depressed and doesn't come to the treatment, doesn't matter if you give him the best treatment of the world, he will not come. That's why we really want to acknowledge to all these people that are not here. I don't know, when we do a tumor board every Monday with Dr. Block, we created a lung cancer tumor board 11 or 12 years ago. I'm very proud to see that now that it's virtual, we see 35 people connected every Monday at 7:30. That's amazing to me, So we give thanks that there's so many people are involved helping us to care every time that we discuss patients every week. And we are trying to discuss the patients because trying to find among all of us the best treatment. Maybe I want to ask, now we will start this way, Dr. Domingo, maybe you can mention briefly, what are the developments? Because the patients ask a lot about target therapy, precision medicine, molecular testing. Maybe you can do a 5-minute glimpse about what we're doing for that.
So there's a lot of new discoveries. It's a very exciting field. There's now personalized medicine in terms of systemic therapy for cancer care. And it includes targeted therapy, immunotherapy, especially for late-stage patients, we always send molecular testing so we can determine the biology of the tumor so we can better decide what treatment would work best for every specific patient. And every day we're finding more and more different targets that we can treat patients with. And those are very, very good because they're oral therapies. Patients avoid all the side effects that we typically see with chemotherapy. And usually the survival and the prognosis of a patient that's found to have a target is much better than someone that doesn't. And each day we're finding more and more, and so it's very exciting in that way. In addition to that, we also treat patients with immunotherapy, and we're seeing many patients that are very good responders to immunotherapy, and also their prognosis has improved significantly. We're also moving that treatment now in the earlier stages of lung cancer. So now it's not only recommended for later stages of lung cancer to test the molecular testing, but also we do it pretty much are all stages. And now we have some recommendations to treat patients even before surgery, to shrink their tumors before they undergo a surgical procedure, which sometimes can also prolong survival or make their surgical outcomes better. And so a lot of new things that are coming in lung cancer. These are very exciting times.
Great, great. And also, maybe you can emphasize about that what we want is to empower you, the patients, about this. You have to request your doctor to do molecular testing, yeah? Because sometimes molecular testing is not perfect. You know, sometimes there is not enough tissue. Like 20% of the time, there is not tissue. So for the doctor nowadays, if you have a lung cancer, say, oh, you know, I'm sorry, there's no molecular tissue, you get chemo. That's not good. You have to tell the doctor, why you don't do a liquid biopsy? You know, send my blood, give me a second chance, maybe we can find a molecular target, so instead to have chemo, I can have a pill. Yeah, but I think we need to empower the patients and the advocates, because if you guys request that, there is no way that we don't do that. But nationwide, only half of the patients with lung cancer are having molecular testing. Only half. Yeah, that's why it's either the insurance or the doctor or the pathologist that said there is not enough tissue. So there is a lot of problems. But if we empower you, this is your right. You know, my dream is to have one of these presidents or Congress to say, okay, the molecular testing is a right. So everybody has to have molecular testing paid, you know? Because otherwise you don't practice modern cancer care, you know? Giving the same chemo to everybody doesn't cure people. So that's why this is very important. Yeah, that part of this message is molecular testing is important. Each of you have to have the molecular testing.
Dr. Reyes, and if I may add, usually for these companies that run the test, they'll try to bill the insurance, but if the insurance doesn't cover the test, they typically do not bill the patients, they'll cover the cost. So the patients don't end up getting billed for the test anyway. So really, everyone should be getting tested.
No, and this is important because sometimes the doctor said, oh, maybe if I already ordered the tissue, molecular testing, the liquid is not indicated, why am I going to order? No. Most of these companies, they are in the side of the patient, they will write off. So that's why we don't have issues in our patients ordering liquid tissue, all the molecular testing. But every patient has to have the molecular testing. You know, that's the most important thing. Otherwise, there is no precision medicine here.
And if you agree with me, the tests are complementary, so really everyone should be getting both, because sometimes you have a result in one, but it's not seen in the other. But as long as you have it in one of the two tests, that's already good enough to get the therapy that the patient would benefit from.
Yeah, that's very important because, for example, today we do the molecular testing in the tissue and do molecular testing in the blood. And sometimes the guidelines say, oh, only do the tissue and you don't find anything doing the blood. But you guys, as a patient, you already are waiting as an average 90 days before to get a medical oncologist, and now it's not acceptable. I tell you, oh, now you have to wait 4 weeks because, to tell you what is the treatment, because that's what the tissue time takes to do the molecular testing. So that's why we do, for example, at Memorial and many academic institutions, we do the tissue and blood at the same time for the molecular testing. And in 7 days or 9 days, we get the liquid, the blood, and we can tell you what is your treatment in 9 days, most of the time. So that is why you don't have to wait. But as Dr. Domingo said, we need to order both. And this is something that we are pushing nationwide, to order both. And don't wait for the tissue to come back 3 weeks later to say, oh, there was not enough tissue. So now we order the blood and the patient keeps waiting for treatment. Yeah, so that's very important. This is something that we have to push and change with the help of the advocates and patients, because that's going to something that benefit the patients, you know?
Dr. Rice, can I ask a question? So, as it pertains to South Florida or Memorial or Baptist Hospital, when you're sending this tissue out, can you explain a little bit about, well, I should say, is it reflex testing? Is that what's happening at Memorial and or Baptist, or does it have to be ordered? And if you could explain what reflex means. And then, what are you ordering? Is it a comprehensive profile? Are we just looking for the 10 or 11 different mutations?
So the reflex testing is what happens in breast cancer. You know, if you have a biopsy of the breast, not only they tell you it's an adenocarcinoma of the breast, they also tell you the markers. They tell you the ER, PR, HER2. So the pathologist sends you a report 2 or 3 days later, complete. There is nothing else to say. In our case, the pathologist said it's a lung cancer, adenocarcinoma, and then he waits for me, or Dr. Domingo, to order the test and wait the 4 weeks. So that's why we keep also pushing the pathology organizations that they have to own and embrace the reflex testing. the same as they do for breast cancer, they should do for us. You know, they say, oh, this is a lung cancer. By the way, before the sample leaves my desk, I went to all the genetic testing. So when the patient goes 2 weeks later to see the oncologist, the genetic testing is there, so we don't have to waste 2 or 3 weeks. That's called reflex testing. That is not standard of care for lung cancer. It's standard of care for breast, but not for lung. And the testing has to be next generation sequencing, NGS, because we have in lung cancer 10 genes that are targetable. We have pills for 10 genes. So to do one test, to do 1 gene, 2 genes, 3 genes is not worth it. It's actually more expensive. And also, we know that there are another 100 or 200 genes that are important. Of course, there is no treatment. Somebody say, why you want to test 200 genes if you only have treatment for 10? Because for the patients that don't have the 10, they have to have hope. Entonces, if we have research drugs for gene 11, 12, 13, and 14, the only way I can treat these patients with the research drugs is if I know which are the extra genes. If I do the minimum, I will tell the patient, oh, you don't have any of the 10, bad luck. No, you know, we have a lot of new drugs for the genes that are not FDA-approved drugs, so that's why we have to do genetic testing, very comprehensive, and our technology allows today to check 200 genes, 300 genes. Actually, the cost is more or less the same. You know, to do 30 genes or 300 genes is the same platform. So it's not much more costly. So.
Yeah, and I think we're talking about personalized medicine, and right now we're in this medical oncology space, part of the conversation focusing on targeted therapies and immunotherapies, and of course, the proper upfront diagnostics being this, call it biomarker testing, genetic testing, molecular testing. It goes by many names, not to only to confuse what's also already, which is already a very confusing disease more, right? So we're talking about it in this instance, I guess, at diagnosis, but can we talk about progression? When somebody truly progresses, what does that look like, and why should we be rebiopsying and relooking at what's going on with their cancer?
Dr. Domingo?
Yeah, so a lot of times, especially for patients that we're treating with targeted therapy, let's say a patient that has advanced stage lung cancer and is on an oral therapy for a specific target, and they start to have some type of tumor progression. Well, at this time, we can always also consider, depending on how many sites of metastases the patient has, sometimes we consider radiation therapy, but typically it is indicated for that patient to get retested, because sometimes the way that the tumor is growing is it develops a mechanism of resistance to that drug, and sometimes the way that is resisting the drug sometimes is another path that we can target with another targeted agent. So it's very important to retest all patients to see if there's an option to change therapy to another targeted therapy, and the patient, you know, can respond and do well, and we can prolong their survival that way.
And I think, sort of to tag on to that, because you did bring up radiation, Dr. Patero, so in the instance of what you know, a big fancy word for, well, the big fancy word is called oligometastatic or oligoprogression, right? So in that instance where maybe the cancer hasn't progressed far and wide, but is in 1 or 2, or I'm gonna let you answer this question, what role does radiation play, Dr. Patero, in something like that?
That was exactly what I was mentioning at the beginning, that you know, not all the stage 4 patients are the same. And you know, for many years now, we know that patients that present with a relatively small number of metastases, we have the opportunity to treat them more aggressively. In terms of radiation, eradicate, basically we have the technology now to target those lesions with a lot of accuracy, so escalate the dose, and not necessarily giving more side effects, actually less side effects, even as you mentioned in your personal experience. Now we treat you know, tumors that are by the heart or by the aorta or by very, very critical structures without no damaging. So for those patients, definitely when we call oligometastases, that are few, we have multiple terms. You know, synchronous, when they present with the primary tumor at the time of the diagnosis or during those 3 months. We have metachronous, but eventually we have this term that after they respond to the therapy are oligopersistent or oligoprogressive. And also the insurance company have become really savvy on that, and they deny treatment with high radiation technology for those patients, which is really sad, because all of them, all the gamma, you call it, if you divide it in 4 groups or 9 groups, because now we have to use the right term, they have benefit. And they say, well, doesn't really make a difference because that patient, you're not changing, you're maybe increasing the local control of the disease in that spot, or maybe you are decreasing the symptoms, but in the reality, the data show that translating survival, overall survival, disease-free survival, and even longer interval of time without need to change the immunotherapy or the target therapy, which is amazing, because even from the point of view of the system, also they are not only the patients benefit, but they also benefit of that. So even those that are, we call them polymetastatic, that at the beginning, they present like a Christmas tree when they use the immunotherapy or the target therapy, and they present now with an oligopersistent disease, they have the benefit. So I think that the, all the science, everything is changing for good for the patients. We have to individualize the case. We have to look at the patient. I make emphasis, we do not treat reports. We don't read the report and say, oh, this patient has 4 or 5. Many times happened to me that the report said 4, 5, 7 new brain metastases, and I go back and see which one we have treated before, and indeed they are the same lesions. So you get an enthusiastic radiation oncology with a new machine, and you get retreated. And the thing is that we nowadays, because we see patients that are survivors for so many years, we now have to be more careful with the technology that we use, because we really certainly want to do good to the patient, but not to make it worse. And in the past, patients, they didn't survive for more than a year or 2 years, right? Stage 4. Now we see them surviving. So you have to be very careful when you recommend something. For example, my speed dial, David is my speed dial. Nothing could be more important than his calls, right? So because I know that when he calls, it's something very important. Read look at my last MRI. So we have to individualize. We have to individualize in the way not only the therapy, but also the patient, and take in consideration what he wants and what is the risk. But we are walking with the physicians. We have to be very careful, because we are walking to eventually see side effects of the treatment that we gave. So the higher technology in radiation that we use, I guess for Dr. Block is the same thing, and for the medical oncologists, we have to be careful. And now we're synergistic. We are using, both therapies that are very potent. So we see the good results, but the potentiation for the side effects. So we are now walking on those days that we have to figure out how is going to be the timing for those therapies, how to obtain the good result, but minimize the potential for side effects. So all these things has to be discussed with good communication among us, the physicians, and communicate with the patient and try to explain it in more kind of a simple way, because they have to be aware that, science is science. We're human beings. We wish to do the best, like I have the power of some God, but we're not. And we have to really make them aware of the potential risk, the potential benefit, and let them also participate, obviously, from that decision. But communication is clue, and being aware that these patients nowadays, even if they present with a polymetastatic disease, you can see them walking with a no disease 5, 6 years later, or even longer.
Yeah, I love the way you talk about risk too, because I think it helps to sort of demystify radiation therapy, because I think a lot of people are afraid of it, right? And to really understand, we talked about, I think Dr. Domingo or Dr. Reyes, you brought it up, technology, right? And how far technology has come, whether it's chemotherapy, targeted therapies, and immunotherapies, and how we're getting access to information. And
main competition for us is Dr. Google. Patients come, and the first word, basically the nurse said, you're going to see a patient that do not want the radiation, that read that he's going to be dead in 6 months, horrible prognosis. Why do they have to go to the treatment, right? So, and it's totally wrong, because it's a curve. Now with all the things that we have, that curve embrace patients that are going to be survivors and with good quality of life, or minimal things, that they can live with. So the first thing when you see a patient is actually to do a little bit of brainwash against the Dr. Google.
It's true, because I think recognizing that the technology is always evolving and getting better, right? But now it's not your grandfather's radiation therapy. I mean, you're able to target, and the radiation field is so much smaller and so much targeted than it used to be, so you're not damaging all of that healthy tissue. So I appreciate you talking about that. And I'm not trying to hijack your conversation, Dr. Reyes, I'm sorry.
No, it's perfect. So I was going to ask Dr. Block, you know, for 20 years, we're giving chemo after surgery because the chemo before surgery that didn't work very well. You know, our lung cancer chemo don't shrink the tumors very well. Totally different from breast. You know, in breast cancer, pretty much I think every lady before surgery, he has to go for chemo. But in lung cancer, no, because the chemo didn't work. So that's why in lung cancer, traditionally, the chemo is after surgery. But if you hear the news in the last 2 years, now thanks to the immunotherapy, we are starting to do more immunotherapy before surgery. You know, so I wanted to ask his impression to Dr. Block. What is the change in this paradigm? No?
So the role of combining surgery with chemotherapy has been an interesting one over the last 20, 25 years. I think when I first was in training, stage 3 disease, which was a lung cancer where the lymph nodes in the central part of the chest are involved, was generally considered a non-surgical disease. And you know, we were doing a procedure called mediastinoscopy, and if the nodes were positive, the patient was not going to have surgery, they'd go for chemotherapy. And what we've seen, I think, over the last 5 years or 10 years, really, is that as the chemotherapy, medical therapy, immunotherapy has gotten better, there is now more of a role for surgery combined with these treatments. So now, for example, stage 3 disease, I mean, you know this, we will give them preoperative treatment and do surgery, or surgery and discover it and do postoperative therapy. Immunotherapy is probably one of the most interesting things for us as surgeons, because we are seeing a kind of response that we never saw with chemotherapy. One of the advantages of being a surgeon is you actually physically get to see and touch the tissue. You see what happens. Immunotherapy harnesses the immune system, which is a multi-pronged attack on cancer cells. It's not the chemotherapy that you target the cancer cell and you make the cancer cell die. With immunotherapy, you're harnessing the immune system to attack the cancer cell. You get an inflammatory response, you get a whole host response. So the cancer cell doesn't just die, you now get scarring and inflammatory reaction across the whole field, which is creating an interesting challenge for us as surgeons, because the surgery is now getting to be more complicated. It used to be fairly straightforward, but now that we're seeing patients who have immunotherapy first, the surgery is a little bit more challenging. There's a lot more scar tissue to deal with. And centers around the country are, we're kind of pooling our data. I just came from a meeting with a bunch of thoracic surgeons from around the country, where there's a lot of conversation about, let's talk about our experience with these patients now that we're starting to see patients who've had immunotherapy. These are patients who never would have come to surgery to begin with. They would have gotten a chemotherapy, probably would have progressed, never would have had surgery. Now they're getting immunotherapy, they're having a good response, and we're approaching the surgery as potentially curative. And it's a challenge for us as surgeons. One of the things that kind of makes you want to come to work the next day is that you're learning something new, you're seeing new things and exciting new things. So it's an avenue that's opened up for us as surgeons that I think is very exciting.
Right. Yeah, I think as a medical oncologist, it's also very exciting, as I said, because we used to wait for the surgery to give chemo after that to try to decrease the chance of recurrence. But nowadays, with the immunotherapy that we give before surgery, the tumors shrink tremendously, something that we didn't see before. And hopefully, that will increase the number yet to patients that can go to surgery. That's something that we haven't proved yet. So far, we are shrinking the tumors, but what we really like to do is to have patients that didn't have a chance of surgery, and now we make it, they give a chance of surgery so we can apply the multimodality therapy. We can do the immunotherapy, we can do the surgery, maybe the radiation, the chemo, so the patient benefits for all the interventions. Maybe we can ask Michaela, one of the things when we want to have program. You know, I think multidisciplinary teams for any cancer are programs. And one thing, for example, for our program, as we mentioned, is different specialists. And I guess everybody agrees that if Dr. Block does lung surgery, biliary surgery, colon surgery, it's not the same. You know, it has to be dedicated. And the same with Dr. Mingo and us, we're trying to focus only on lung cancer. But the navigators are very interesting, you know. So sometimes for us as a doctors, it's a challenge to convince the administrators of the healthcare system why we had to hire navigators. You know, I remember I had to go to the president of the healthcare system to convince him to hire 5 navigators for the cancer center 10 years ago. And not because he was against. He said he didn't know why we needed to do that, so he invited me to have breakfast and convince him. And after he finished talking to him, he said, okay, we'll hire them. But why is so important the role of the navigators in cancer?
So when the patient is referred to oncology, most of the time, what we do, we are the first contact to the patient. So they don't know where they're going, why they're being referred. Most of the time, they're scared about calling an oncologist to make an appointment. And my role, first of all, is to make sure they get an appointment within 72 hours, 48 hours, if possible. And I get the records from whatever we have available. If they have a biopsy, we schedule the patient right away. If the patient, for instance, doesn't have a biopsy, and he sees or she sees an oncologist, then we are delaying the patient's care because then we refer the patient for a biopsy. So my role is to understand the patient's story, review the records, and obviously discuss with the oncologist. If the patient needs a biopsy, we refer the patient to the thoracic surgery or to pulmonology. So we speed up the process. It's very interesting that Dr. Reyes has initiated a multidisciplinary clinic. Usually it's Tuesdays. On Tuesdays, so patients newly diagnosed with cancer, then they are meeting with radiation oncologists, medical oncologists, and surgical oncologists if needed. So my role is also to help the patient to have all the appointments scheduled and also communicate with the oncologist whatever issues we have related to that. So this is somehow helps patients and to get access to care, get obviously the staging completed right away as fast as we can. And also we facilitate their treatment to start right away as far as we can, and in terms of results and all this. So I feel like, first of all, we're saving time, we're saving lives, just making sure everything is done as fast as we can. Another thing that's very important for us besides that, a lot of patients are not able to get access to care, and they don't speak up. They see the doctor, and then after the appointment, when I follow up with them, sometimes I notice that they're so confused and so anxious about the whole new thing about what is this, what do I need to do, what's a biopsy, why do I need to see a radiation oncologist or a surgeon? I'm afraid of that. So my role is to make them understand the importance of following up and following through what they need to do. So in terms of leading them to have a successful experience with us and see them fighting this cancer, I think the role of the navigator, generally speaking, is as important as any other team member or medical team member, because sometimes patients cannot come to the appointments because they cannot eat, so we have nutritionists. So the patient may not say at the appointment, but then following up with them, we realize they cannot eat, they don't have transportation, or there are other things that we cannot really discover at one appointment. It's always a reinforcement, always an assessment. So that part is the back of the ground of this work is carried out by the navigator as well. Also very important, I feel like we have to be an advocate for the patient. Sometimes, as we all see here, it's been like a very long process. So the worn out part of, the caregiver and the communication with the patient and the caregiver sometimes helps the patient to continue and try new things and understand why we need to switch treatments. Why is this important? I don't want to give up. Some patients want to give up, but then discussing with them and see by example what are the benefits of continuing the treatment. It's very rewarding. At least for me, that's I have seen in a few years. I've been really amazed about the resilience of patients. But also I realize our role is as important as, as to really connect everything and keep it together so that the patient will have such a successful outcome. In terms of, we have something that we always try to also implement new things. Like recently we have financial navigator. We all know what does it mean to have insurance, co-payments, and sometimes it becomes a burden for patients. They don't want to come to the appointments because obviously there's overwhelming, invoicing is too high, or things like that. So we have recently implemented for lung cancer patients a tool that's called financial toxicity tool, and helps patients to help us to identify what, let's say, issues that the patients have. So we have a financial navigator reaching out to them and so forth. So our role is throughout this process of helping patients through cancer care is never ending. It's always something new. Survivorship is also important. We connect with patients on and on. We explain what is a psychologist, why is it important for the caregiver to come and be a part of the process with the psychologist and the patient. What are the benefits for you? The social workers, sometimes patients go through different other issues because life happens. So we want to make sure we stay connected with other professionals and help them out on that particular aspect. So I would say, as we know, a lot of treatments are new treatments. We also connect with the research team. And if we identify a benefit besides Dr. Reyes and the other oncologists, if we know that we will find something that will help the patient in terms of research, we also connect with the research department to discuss that. There are a myriad of tools that would help patients, and we all understand that everyone's story is very unique. So the navigator, my mission is to make sure we tailor everything as much as we can, our care, to help you as much as possible.
Great, thank you. Thank you.
Sure.
You guys want to ask any question, any comment? Yes, please.
So it's a three-part question. I was diagnosed in 2016 with lung cancer, had CyberKnife in 2017. Since then, I've been good. Never smoked a cigarette in my life, raised in a smoke-filled household, and as a former flight attendant, worked in a smoke-filled cabin for many, many years. My question, first point, is how dangerous is vaping, whether it's for cigarette substitution or CBD, for example? Second question is, do you foresee a time in the future when we can go to these, quote, drip bars and do something for ourselves to prevent cancer? And the third part of the question is, do you foresee a time in the future when there would be molecular testing in general, like we go to our primary to do lab work every year for metabolic panels, et cetera?
Perfect. You do the vaping.
I'll take the vaping one.
Do the vaping.
I'll take the vaping one because I recently did a live webinar for the Lung Association on vaping. And it's a controversial topic, for sure. The problem that I kind of eventually focused on was that we really don't know. There are a lot of things we do know about vaping, but the bigger questions, I think, are really up in the air. And what I wanted to illustrate as part of my presentation is I showed ads from the 1950s and 60s for cigarettes, you know, with doctors about how great it is to smoke and so forth. And, you know, this is 30, 40 years after people really started smoking cigarettes. And it wasn't for another 10 years before we realized that cigarette smoking was a major cause of lung cancer. So vaping's only been around for, what, 5, 10 years at most? It will probably be another 20 or 30 years before we really understand the long-term consequences of vaping. But what we do know are a couple of important things. First of all, vaping is a misnomer. It's not a vapor, it's an aerosol. It's a particulate matter that you're inhaling. It's not a vapor. You know, like you boil water, you get steam, that's a vapor. An aerosol is what you spray around the house that has little droplets in it. So when you're vaping, you're actually inhaling an aerosol. And that aerosol contains hundreds of different chemicals that vary from one product to another. There's no consistency between them. There's no regulation between them. And there's variability from one batch to another from the same manufacturer. We know that they contain a number of chemicals that are known to be toxins and harmful, that can be carcinogens, although I think it is pretty clear that there are fewer carcinogens in the aerosol from a vape than from a cigarette. There are fewer carcinogens, but there are still toxic chemicals in there that can affect the short-term and long-term health of the lungs as well as the rest of the body. So we don't know the long-term effects. The short-term effects can be toxic to the lungs. The long-term carcinogenic effects, causes for cancer, up in the air. We just don't know that for sure. Probably the biggest concern, and I think the reason the Lung Association is so concerned about vaping, is that number one, it targets youth, and number two, it creates an avenue for addiction to nicotine. So nicotine is an incredibly addictive substance. It's actually the most addictive substance that we are exposed to. It's more addictive than heroin, cocaine, anything. There's a very strong genetic predisposition to nicotine addiction. So once you become addicted, it's extremely difficult to quit. You know, Mark Twain said it's easy. I've tried it, you know, I've done it 100 times, right? But quitting nicotine is very hard. And so getting our youth addicted to nicotine through vaping is really the thing that the Lung Association and all of us in the healthcare industry, I think, are the most concerned about. Vaping is also associated with CBD or marijuana use. There's emerging data that the increased exposure to those chemicals over what people were, you know, when you smoke a joint, now they're exposing themselves to a lot more of that chemical. That has potentially toxic effects as well. So vaping is bad. How bad, we won't know probably for another 10 or 20 years. But there's a lot that we do know that's bad.
Yeah, I only want to add that if you catch what Dr. Block said, we started to, you know, in college to smoke some cigarettes when we were 18, 19, because we couldn't buy before, you know. But the vaping is okay, you know. In every high school, all the kids are doing vaping in the bathroom, you know. So that means that these kids are they have
middle school.
They are starting 5 years earlier, so they have 5 more years than us to get damage. And the other thing is what the cannabis. I am sure that the cannabis that our grandpas smoked, that was Mickey Mouse, you know, compared to what we smoke now. You know, so because, for example, the other day, one of our nurses, unfortunately, was called to the school because the son was found unconscious. He has burned some cannabis in the vaping, and he was in ICU. He was flat in the ventilator for several days because the concentration was 70%. It was 70, you know, so there is no control for these things when you buy in the streets. This is not the cannabis that our grandpas used to smoke, you know. That was recreational, that was gusto, you know, there's no matter harm. Now they are really doing more concentrated, and if it's illegal, you don't have any control of how much they are putting there. You know, how do you know? So those are the caveats. Regarding the testing, yeah, we're really tired to this screening with imaging. You know, you need to do 800 mammograms to catch one breast cancer. You need to do 250 CAT scans to do a lung cancer, and even in only a high-risk population. So that's why we're very close. We're very close to have the blood draw to identify the cancer in the blood. So until today, we don't identify any cancer in the blood other than leukemia. What we identify in the blood is the markers, you know, the PSA and the marker of ovarian cancer, but they are not very accurate. They are not very accurate. That's why what we are very close now is to identify the real cancer cell in the blood. And there are several vendors. I don't want to advertise for them because none of them are really there yet, but they are very close. They are very close. That's why we have a lot of hope that one day, maybe in 2 or 3 years, you go to your primary care, you check the cholesterol, the hemoglobin, and then he checks the test for screening for 50 or 70 cancers. That would be amazing. So we don't have to be doing CAT scan, we don't have to do a mammogram or any other test empirically. And the cost is not a big deal. We are paying now for 1 CAT scan a year, whatever amount, that can be paid for a blood test, but the patient don't get exposed to radiation. That's why we have a lot of hope in this new technology. So. Any other comment or question?
I just want to mention also, and Dr. Block can correct me, because I also did some presentation about vaping several years ago, and the data showed that those patients that try to quit smoking, that get into vaping, 60% of them grossly stay with both. They don't quit, stay with both. But I don't know if that's the numbers now.
Yeah, so one of the controversial issues about vaping is it an aid for smoking cessation or not? And unfortunately, we don't have very good data on that. It's all kind of observational data. But Dr. Botero is right. There's a large, pretty much every study that has looked at it has shown that people who use vaping to quit smoking wind up doing both.
They don't quit. Some, but they don't quit. They just get the problem worse. And by targeting the youth, and by youth is a very,
very young
if you ask me what is young, I would say I'm young, and don't ask me how old, right? Because the term of, but certainly it's concerning because youth, you are used to think that smoking in high school, but this is in middle school, kids on the bus that they are sharing. So it's very worrisome because the data that we're going to, the results is going to be in 10 years, 15 years, but we saw the population in the world declining in smoking, and we were very happy, right? And now it's just like going up. So we're seeing this kind of, we're going to see the results of all these things. And try to convince them that vaping is not good.
So I will say that some of the most recent data show that vaping among teens and youth has leveled off. It's not continuing to rise. So the advocacy efforts, I think, are paying off.
That's good. Hours of them.
Yeah.
I think we've touched on, there's a question? Yeah, Michelle, right here.
Thank you. First, I want to thank Dr. Block for the good surgery you did on me, and Dr. Botero for finding a blood clot that others weren't able to find. So thank you so much. My question is in 2 parts. I understand that for early detection, blood tests are available. And I want to know, like for people like myself who have been without active cancer, and this question perhaps goes to Dr. Reyes, would that be something that would be available to someone like myself, for example, who is now 5 years out just about, and would that same blood test be of help to me to detect early cancer?
Yeah, the problem is, or the test I mentioned is that they are not ready for massive use. But it's dangerous because if you go to Google, they're already there. And you pay $600 and then they will come to your house and they do the test for you, The problem is that they have false negatives and false positives. So as long as you can live with, for example, you don't have any cancer and you come positive, lung cancer positive. We do your scan and we don't find anything. Maybe it's a false positive. But then how you're going to sleep the next 3 or 4 years every night thinking, oh, I really have lung cancer. It's coming, when it's coming. And maybe it's a false positive. So that's why the tests are close, but they are not ready. That's why we don't advertise, we don't commercialize. For example, in Memorial, we have bought 1,000 tests, and we want to do a research project. So you need to sign a consent, but only the people that is willing to endure the consequences to have a positive test if we don't find the cancer, or to have a negative test and maybe we miss the cancer, That's why the tests are not ready yet, but we're very close. For survivors, it's different. For survivors, we have other technologies, and then also they're very close. After surgery, for example, we are trying to discover, after surgery, in any cancer, breast, colon, lung, we give chemo like water to everybody, you know, and now we used to do only chemo, now we give chemo immuno, so we're more sophisticated, but we're still giving like water to everybody. And some patients don't need it, they are already cured, but we don't know. We don't know who is who. Yeah. You know, it's like, I love Star Trek when they do like this from head to toe, and they say, oh, there is a virus there, or there is one cancer cell there. We don't have that technology. So that's why this test that we're developing now, after surgery or after your chemo and you're clean, we do the test and we really know if you have cancer, residual cancer or no. If you don't have residual cancer, maybe we'll spare you the chemo. After surgery, you don't need any chemo because they already cure you. Or if you have 3 cancer cells hiding there, we'll give you the chemo. These are tests for minimal residual disease. We are also working on that. You know, there is tons of technologies, different companies, but we haven't decided which one. I think in colon cancer, they are very, very close. That the FDA already has one technology that after your colon cancer surgery, they can use to track if the tumor is coming back or no. But in the other cancers, we're still a little bit behind. But it's very exciting for us because honestly, if 100 people have surgery, the idea to give 100 people chemo is not a good idea when you know that maybe half of these patients are already cured, you know?
I also have another question, and it's regarding sugar. There's been a lot of controversy about eating sugar. I'm very fond of chocolate, and I've eaten chocolate throughout the years. Chocolate's my friend, but what's your take on it? Anyone?
So, yeah, I get this a lot. You hear a lot of mythology in surgery, like, you know, cutting on cancer makes it spread, and should I avoid sugar? I'm not sure where that came from. My guess, my take, is that we use PET scans to diagnose and stage cancer. Right. And as all of you probably know, cancer cells take up the activity on a PET scan. Well, the chemical that you're given when you get a PET scan is glucose, it's sugar. It's radiolabeled sugar. And so sugar is the fuel source for all the cells in our body, except for the brain. So the cells that take up a lot of sugar show up bright on the PET scan. So I guess somebody made the leap of, you know, A plus B to C to DD is that, well, if you're given sugar to light up the cancer, then the cancers must feed on sugar, so you probably shouldn't eat sugar. That's my guess, and I'm open to alternative theories.
You can quit on the sugar, you will kill the person, the patient first. You know, you certainly cure the disease, but you really basically kill the patient. Patients lost weight, they are losing the most important thing, that is their own immune defenses. I think that balance, for me, but I don't know from where these diets come from, because sometimes if it's not the sugar, it's the meat, it's the alkaline, the famous alkaline diet, and the patients that swear over those diets that they get better. They don't look about the, you know, about the other things that are going around. They think that just the diet. But in the reality, I think that with moderation, exercising with moderation, eating with moderation, obviously gaining weight is not in your own, you know, benefit. So I think that nutritionist is very important part of the equation, you know, but they need to eat. If you really, plus the torture of not eating absolutely nothing, no sugar, you know, I think that is almost criminal.
Especially foods that you enjoy.
Yeah.
You know, I think.
Yeah.
Well,
no, we want you to be.
I eat a piece of chocolate, I say to
yes,
my...
go with for a piece of chocolate.
We want you to be in good spirits so we can fight this. And but something that Dr. Botero just reminded me is obesity is linked to cancer for sure. And among survivors, same thing. You know, your chances of cancer recurrence or survival are worse when you're obese. So that's why that part, you know, if you are obese, whatever, overweight, yeah, you can do a diet, but you have to consider, especially in lung cancer, patients lose a lot of weight. That's why we'd rather have you in a good weight than losing weight. You know, that's why diet is very hard in our patients.
So let me just add to that kind of a surgical perspective. People often want to know, what do I need to do to prepare for surgery? And I tell them the most important thing is maintain good nutrition. We want people to be stable or even gaining weight going into surgery, because surgery is a very traumatic event. and your body requires all of its energy stores to heal from surgery. And one of the really interesting bits of data that's come out in the last few years is that people who are actually overweight, you know, that scale from the government about normal weight, overweight, obese, 1, 2, 3, people who are actually overweight have the lowest mortality rate with surgery.
Huh.
They actually do the best with surgery than people who have normal weight.
Paul, that piece of chocolate cake.
So maintaining your nutrition.
My name on it.
You're maintaining
there is plenty of cookies in the back, so there are plenty of cookies there. So.
I just want to make one single comment about the nurse navigators, how important they are. Try to call yourself to a hospital and set up 3 or 4 appointments, not knowing which one go first, not knowing. Try to talk, even if you're under treatment, try to talk to Dr. Rice. And how many people, or Dr. Block, how many do you go to the main operator, then the office, and maybe you're lucky if a few days after he heard that a patient is trying to get in contact with you.
Paola calls the same day.
Well, but that's what I'm saying. It's very important. It's like a VIP treatment, you know? The nurse navigators, they know exactly about what is the criteria, the importance. So it's extremely important job, you know, because it's basically like a hand-to-hand. This is the first appointment, and they have the connection. They have the right person to contact, you know? The timing to see the doctor, how many times you receive patients that they said, I have been 20 days since my diagnosis, or 30 days, and you just happen to put it on the schedule 2 days ago. They come frustrated because they haven't started treatment. And they said, am I going to start my radiation right now? And you think, oh my God, I haven't even, you know, you have to sign the consent, you have to send it to the insurance. Insurance might even say, no, I don't approve the technology. You have to fight for another 2 more weeks, and then eventually the plan in another 8 or 10 days. So you're thinking the patient wants to start the treatment right away, and you have another 3 weeks. Your colleagues are calling, why you haven't finished the radiation? I'm waiting for the patient to give this and that. So nurse navigators are crucial, you know, in the system to basically guide the patients, but with criteria, with knowledge of, you know, what is the best for them. I really think that is very important part of the institutions, you know, as part of the multidisciplinary approach to the patients.
I just want to say something. I remember 13 years ago when David was diagnosed with cancer, they only gave him days to live by that time. And I remember the first doctor just told us he has days to live, there's nothing to do with him. But someone else told me, get a second opinion. And that's the way I found Dr. Rice. But I remember that when you get cancer, everybody has the solution. Everybody tells you what to eat and not to eat. But Dr. Rice, I guess in a way, he always gave us hope, and that's what we love Dr. Rice. Because he always gave us hope. But I remember they telling us that not to eat sugar and not to eat red meat. And Dr. Rice told David, you eat everything that you want to eat, everything. And David did. And we didn't think that it was because David was going to die, so it doesn't matter. Eat whatever you're going to eat because you're going to die anyway, right? So he ate everything. And look, he's still here. So, and another thing that we learned, like Dr. Botero was saying about Dr. Google, that's something that we are also learned. We don't look at Google for nothing, First, God. Second, you need to trust your doctor. You need to be buddy-buddy with your doctor. And then you don't go to Google, because when you look at Google, everything is bad. You're gonna die tomorrow. There's 99% of the people dying, so why to look at that? What you need at that time is hope, positive. So that's what we had learned during these 13 years, and it has been working to the point that the first 5 years, and I'm not kidding, we stopped completely the news. For 5 years, we didn't. The only thing I will put today was things that will make him laugh and laugh and laugh and laugh and laugh. But we never saw the news anymore because everything is so bad. So that's just a comment.
We had the same situation when you get out, come and see me. And we did, because we didn't know anyone. And he gave her 6 months, at which point I said, you know what, you're not the doctor for us. I made some phone calls to people, family in the medical profession, said, who do we go to? And they suggested, I can't think of the last name, at the time at Sylvester, Felix? I can't remember. Anyway, we called and they said, no, he's no longer with us. He's now up at, what's the one in Tampa? Moffitt. And we said, well, who would you recommend? They said, well, give Dr. Ayers a call. And we did. And we knew there was no answer to say, we can cure you or whatever. We were just looking for hope. And that's what Dr. Ayers did. He gave us hope and pretty much said to Audrey at the time, you know, you're in pretty good shape, and I'm gonna treat you pretty aggressively, and if it's too much, you gotta let me know, and I'll cut back. And he did, and 15 years later, thank God, my wife is here. So thank you.
Daniel.
Dr. Botero, she's so special, but she goes the extra mile as well as Dr. Rice and everybody else. She does. Oh my God, it's unbelievable. I really don't want to bother her. When I call her, it's because I really need her, but I try not to because Dr. Botero is too much. She's great.
We're a little over time, which is not a big deal, but I want to be mindful of it for sure. And I think we've talked a little bit about a lot of things today. And you know, each one of these disciplines, plus the ones that Dr. Reyes talked about that aren't even represented at this table right now, we could have multiple separate meetings talking, you know, through each different piece and each piece and each role that these amazing people play. But I think for me, what I hope you guys take home is how important it is that you do have multidisciplinary teams looking at your cancer. No one lung cancer is the same, right? Everybody's cancer is different. Everybody, you know, reacts to their treatments different. And so having all of these eyes on your specific cancer is so incredibly important. And I think they would argue and agree, not argue, they would agree that they learn from one another too, right? They all specialize in their own place. And so really kind of having those conversations about any one patient, I think, is incredibly important. I want to say a huge thank you to this panel for coming and talking to us today. An even bigger thank you to all of you who showed up here today and participated and sat here and listened to everybody talk.
And thanks to you for putting to
together.
to all of you to put it together because you know.
I want to thank everybody watching online. I want to thank the Beverly Boys in the back there for showing up early and getting all this set up today. The historic Maxwell House, I absolutely love this event place. A huge thank you to them for all the work they did before we even got here later this afternoon. I hope you guys will come back. We plan on doing, we're back live, we're in person, we're going to be doing this every year. And I know it's been kind of slow as we've kind of brought the live sort of thing back, whether it's in our events or even at our gala this year or the living room and things like this, getting people feeling comfortable to be back live and kind of close together. But thanks for kicking it off for us. We really appreciate it. I do need to read off this list to thank our supporters. Without the support of in particular, our industry partners who believe that empowered patients, or that patients deserve empowerment and that empowered patients do better. And you heard all about this today. You guys learned from Ben, you guys learned from one another. And it's important that you read up, not through Google, but through reliable resources like your physicians or organizations like GO2 or other lung organizations out there that have vetted and verified, accurate, up-to-date information is really important. So the supporters are Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati Therapeutics, Novartis, Regeneron, Sanofi, and Takeda. That's a really long list, which I think goes to show that they recognize the importance of this patient education empowerment. So thank you all for joining us here in South Florida. I hope everybody gets home safely, and we'll see you next time.
So I'll be brave if you're brave. I'll be brave, but only if you're brave. So I'll be brave if you're brave. I'll be brave, but only if you're